I'll call this meeting to order. It's Wednesday, June 26, 2024, 11 a.m. And we are here to the Ambulance Service District Financial Policy and Billing Rates with System Design. I'll turn it over to Chief Dietrich.
Okay, so I was actually having a conversation with System Design, our billing company, the other day about our billing rates, and I guess a part of it was a little bit of my inexperience. I didn't realize that we set those. I just figured that was a standard number that was set, but it's not. So we set our own billing rates. Before I get into the rate discussion, I'll just kind of give you guys a quick history on how EMS billing works. So there's basically three different categories of patients that get billed. The biggest category is people that have Medicare or Medicaid, and then we have the private insurance and people without insurance. Medicare and Medicaid, they pay us a flat rate. Doesn't make any difference what we bill them. They're going to pay us a flat rate.
Right.
Other than the mileage surcharge. So if we increase the mileage rate, they will pay the extra for that. But they're just going to pay. So the discussion on the actual billing rates for most of our people in Shoshone County that we transport are in that Medicaid, Medicare arena. It's not going to really affect them at all. The private insurance, for the most part, there is some exceptions, but for the most part, when we increase our rates, as long as it's within the kind of the regional national standard, they'll pay an increased rate from their insurance company. And then obviously the people that don't have insurance, they're just going to get billed directly. A lot of those we either don't collect or the billing company will make some sort of payment plan with them. I've heard as low as like $5 a month for ever that they pay
Social services
to avoid going to collections or whatever. But that billing agency takes care of all that.
Okay.
And so when I was having the discussion with her on her rates, our rates haven't been increased since the ambulance district was established 3 years ago. And so I wasn't quite sure. I'm like, okay, well, where do we compare to everything else? So in your packet, you'll have this sheet. This is the agencies in Idaho that System Design contracts with, their current rates, just so you guys have that to kind of compare.
Okay.
And some of these are lower than ours and some of them are higher. She said all the ones that are lower than ours are kind of in the same boat where we are, where they just haven't updated their rates in years, and they all need to update theirs as well. But I didn't go like max, like with the numbers I chose. I kind of went middle of the road.
Okay, I see that.
Okay, and then
Now,
these
are the new rates. I'm sorry. Right here where it says Shoshone County and that's the new rates you're putting in.
No, so
that.
you have two more sheets. One of them, these look almost identical, but the one that's not stapled, that just has the rates across the board, that is our current billing.
Okay.
Current rates.
The other one that looks similar to that that's stapled is the new proposed.
Okay.
Now you'll see the other thing that we added in this one, which is done in a lot of Idaho agencies, I didn't know, they have a resident and a non-resident rate.
Okay.
So the non-residents actually get billed a little bit higher rate.
Mm-hmm.
Now, in Shoshone County, this might make a little bit of an impact with us because a lot of our non-residents are our younger population that are coming to recreate or the ski resorts, and they're mostly private insurance, not Medicare, Medicaid. And so if we do increase our rates a little bit for them, we might get a little bit more bang for our buck.
Okay.
And again, it's their insurance that's paying out on that.
Okay.
But then the rates, you guys can read the numbers, but they didn't go up drastically. But like for the BLS NE is non-emergency transport. So that would be like from Shoshone to Cooney. It's not a 911 call, it's an interfacility. The BLSE is emergency, and so that would be like a 911 call.
Okay.
And then there's two different versions of ALS. There's ALS 1 and ALS 2. That just depends how many procedures we do. If we do an IV, I don't remember the exact thing, but I think it has to be 3 or more procedures. So if you do an IV, EKG, and medications, and then I think maybe it's more than 3, then it's an increased rate just because we're using more equipment and more supplies. But that's purely just set. The billing company will read our report, see what we did for interventions, and they will determine whether it's ALS 1 or ALS 2.
Okay.
The SCT is like a critical care transport. That's a paramedic level transport from Shoshone to Kootenai, per se, or Shoshone to Spokane. So those are the base rates that you see. And then, so
Those are transports.
Yeah.
Okay.
we this is all transport costs. And then the mileage, so that would be the base rate, and then it's just for the example of the proposed one, the mileage rate's going to go for a resident to $20 per mile, and a the non-residents the same, both $20 a mile. So that'll be just added on to whatever the base rate was,
Okay.
and that's the total billing for that call.
Okay.
Does that make sense so
Yeah.
far?
It does.
The other thing that we are proposing is changing billing policies for non-transports. Now, historically, we only bill for transport. When I was talking to the billing company, she said that we actually had language in our contract with them that we could bill for non-transports, and it's never been done.
Mm-hmm.
But on the policy manual, this multi-page book, if you go to the very last page, there's a list of services that we want to bill for non-transports. It's basically, if we're going to treat we're not billing for assessments.
Mm-hmm.
We're billing if we're doing a bunch of interventions, and then the patient's like, okay, nope, I don't want to go. Well, we just spent a lot of money and equipment.
Yeah.
And so the things I want to include for billing is if we start an IV and give them any meds or any fluids, if we administer any medications, if we do a full 12 lead, so not just hooking up the cardiac monitor, but if we think it's an MI and we're doing the full 12 lead EKG, a needle thoracentesis, the likelihood of doing that in a non-transport is pretty slim, but that would be for someone that has like a tension pneumothorax and we put a needle in their chest to evacuate the air. They are going to need to go. But there's a chance that we could do that. And then the patient might die and we might not transport them, but then we could bill for at least the procedures.
Okay.
Same thing if we have to cut through their neck to establish a surgical airway, and we don't transport that. And then the cardiac defibrillation, cardioversion, or pacing. So those basically, like we have patients cardiac arrest. Historically, when we didn't have paramedics here, every cardiac arrest, unless it was like obvious death, they had to transport because anybody less than a paramedic can't make that determination on scene. But now with paramedics, a lot of our cardiac arrests we don't transport. A paramedic can do every intervention for a cardiac arrest that they can at the hospital, and it's a higher chance of survival if we don't transport because the CPR is better not in a moving ambulance. So now a lot of the times the patient has a much better chance of survival if we work the cardiac arrest like in their home. But then if we work it, it depends on the patient, but sometimes it'll be 20, 30 minutes of actively working the patient, doing a lot of procedures, a lot of meds, and then we'll call the doctor and have the conversation like, yeah, this patient's they're not coming back, and so we'll leave them there. Well, those cost us a lot of money. And so those ones would be another one that we would then bill, and it would, go to that patient's insurance, or if they had insurance, whatever, Medicare, Medicaid.
Okay.
So in order to make these changes, when I talked to the billing company, the updated policy manual, which is this one, and basically the only changes to the policy manual or the billing manual were the added of that last page I just went over.
Okay.
So there has to be minutes that you got, if you choose, minutes that you approve the policy procedure manual changes, and minutes that you approve the new billing rates. And then once I send the minutes to the billing company that you approved both of these, then they can get it in motion. But do you have any questions or anything I wasn't really clear on? I know that was a lot really quick.
No, I thank you for your time going through this and getting the expenses and
You bet.
Is there any kind of coverage for those that don't have insurance that you know of that they, like our Life Flight does?
No,
But there's no.
there's some
kind of little
private
program.
ambulance companies that will do contract services, but I don't know of any public agency. There might be some, but I don't know of any that does that. And that alone, we would probably spend as much money in administrative costs just managing that we would ever gain in the end.
Yeah. Well, hopefully everyone has insurance now.
Yeah, by far the most people. And most people that don't have insurance end up just not paying.
Mm-hmm.
And then I guess I didn't, there is a language in here that it's done kind of with the billing company. If a patient, there's a form that they can fill out. If they're like, I don't have money, I can't pay this. Then they fill out a form saying, yeah, here's the reasons I can't pay it, I don't have money. And then that gets sent to me. And if it all looks legit, I just tell the billing company to just disregard
Right.
billing and we just write it off.
Mm-hmm.
That we don't get a lot of those, but we probably get 5 or 6 of those a year. So
All right, any other questions?
No.
Are we ready to move on it?
Mhm.
Okay.
Yeah.
I'll entertain a motion to approve the policy procedure changes and the billing.
So moved.
Okay. I'll second it. Is that basically it?
I think so. I think that's all I need. They just needed language to both of those.
Approving
were approved.
both, yeah.
Approving both the billing and the procedure. All in favor?
Aye.
Aye.
All right.
Motion carries. It's passed.
Thank
you for your time.
You bet.
Meeting's adjourned.
Easy.